Dear colleagues, as we unfortunately had to cancel this year's World Congress in Montreal, we thought it would be a good idea to at least share some highlights from the virtual Congress that took place in February. Before the video starts, I would like to announce that the 2022 World Congress in Taipei, Taiwan will take place from June 9th to the 12th. I look forward to seeing you there in person, and now please enjoy the video. Oh, and don't forget to subscribe to our YouTube channel below for free so you can watch more videos in the next weeks. Thank you.
So my name is Joseph Zohar. I'm from Tel Aviv University, and I'm going to be the first speaker on the clinical focus and frontiers, focusing on OCD. And I'm going to talk about diagnosis. As all of you know, there has been major changes there. In the past, and over the last 30 years or so, the diagnosis has been focused on clinically based syndrome, on the symptoms that we are seeing. So we base the diagnosis as, whether the patient were in OCD, the washing, the counting, the checking, the express behavior. And based on this express behavior, in DSM-4, the classification of anxiety disorder included PTSD, post-traumatic stress, phobic, generalized anxiety, panic, and OCD. So OCD was part of the anxiety disorder. Moving on to DSM-5, the DSM-5, the intention was to move further, to provide a better match between neuroscience and classification, sort of to bridge between the neuroscience and the clinic, to do this kind of bridge. And the way they were thinking about doing it is by adapting what we call endophenotypical approach. The endophenotypical approach is basically something in between the etiology, the genetic in environment, and the express behavior. So the idea is to go beyond, underneath express behavior, something like brain circuitry and cognitive function or other, that are not just relying on what we are seeing, but sort of looking more deep inside the pathology. Let me give you a description of case of OCD, and then you see the difference between anxiety and OCD. So this is a typical case. This is a 32 years old lawyer, is functioning. Nobody knows about his OCD. He is managing to hide this. And then he told me that he need to enter the bedroom with left foot first. Don't step on the cracks. Touch corner mirror 8 times. Then look at left hand 4 times. Taking 2 steps back, look at right hand 4 times, 2 steps forward, don't step on the cracks. Move the toothpaste tube on the counter, go to look at the thermostat in the living room, enter the bathroom with left foot, don't step on the cracks, stand straight, and listen. And then he told me, if I hear running water in the building, or if I feel that somebody else is brushing his or her teeth, feelings that somebody else is brushing or her teeth, I have to start all over again. And if I can proceed, I have to stand away from the faucet so that nobody else in the building will be standing in the same spot. So this is someone who is functioning, and this is the ritual that you need to go every morning. And the reason that he is doing it, that he has this kind of magic feeling that if he will not do it right, something terrible might happen to his nephew. So if OCD is so prevalent, why don't we diagnose OCD more often? And this is where we're going back to the ego-dystonic nature. The patient is aware, per definition, most of the patient, not the psychotic one, not the delusional one, but most of them are aware that what they are doing or thinking is excessive or irrational. So many of them are hiding their symptoms. They don't tell you out front about their symptoms. So how we can improve the diagnosis of OCD, what we can do, what we recommend, and this is part of the NICE guideline. We recommend about 5 screening questions to identify OCD, and to do this 5 screening question every time that you're seeing OCD patient. And these 5 that you're seeing any patient. Anytime that you're seeing any patient, you need to spend this, you ask this 5 question. Do you check things a lot? Do you wash or clean a lot? Is there any thought that keep bothering you that you'd like to get rid of but cannot? Do your daily activity takes a very long time to finish? And are you concerned about orderliness or symmetry? If you ask this and you get positive, then you can move into this. And many times, even for individual or patient that I'm seeing, that there is no any sign of OCD while you ask this specific question, you realize that there is OCD in the background. So I think the most important part of this talk is to remember this 5 screening question and to make sure that each time, anytime that you're doing mental status examination, to ask this 5 screening question accordingly. We talk about what, in my point of view, is the most important thing, is to make sure that we are not missing OCD patient, and the way to do it is make sure that you ask this 5 screening question to identify OCD every time that you're doing mental status, and this includes, do you check things along, do you wash or clean a lot, is there any thought that keep bothering you that you'd like to get rid of but cannot, do your daily activity takes very long time to finish, and are you concerned about orderliness or symmetry? We make a point about assessment of family accommodation and making sure that we are evaluating OCD patient. We need to open our eyes not only to the patient and include not only the patient but the family, and to make sure that what they are doing are not supporting the OCD of the patient. And then we mention about OCD during the COVID-19. And what I mentioned is that there was no clinical exacerbation, neither in the first 2 months or 6 months, in patients were in active treatment, and that there was no any specific exacerbation in patients that we expect it to be a patient with contamination and hypochondriasis. So basically, in this talk, we covered the diagnosis. We mentioned that OCD is not only one disorder, but has the related disorder. We say that OCD could be psychotic and still be OCD. We talk about the 5 screening questions that we need to do each time that we are doing the OCD, the need to look at family accommodation, and there's some sort of counterintuitive finding that in treated patients with OCD, COVID-19 did not penetrate their OC symptoms, and the implication is that we should continue to treat them as we use for this patient. Thank you for your listening, and I'm open for question in the second part.